Hi, I'm Dr. Chris Samuels, and if you're a clinician working with couples in the aftermath of sexual addiction or betrayal, you already know how chaotic those sessions can be. The partner is flooded with pain, fear, and rage, and the person in recovery is drowning in shame. Both are looking at you to fix it. And often both are convinced that the other person is the problem. The pull to take sides is enormous. The partner's pain is so visible that it's natural to want to validate it, and it should be validated. But if the person in recovery experiences you as the partner's advocate rather than a guide for both of them, you've lost him. And if the partner senses you're protecting the addict from accountability, you've lost her too. What I've learned in over 30 years of doing this work is that the clinician's most powerful tool isn't empathy alone, although empathy is essential. It's structure. Structure doesn't replace compassion, it makes compassion effective. Today, I want to walk you through 6 elements I've found essential for working with both partners without losing either one of them. Let's start with the partner because that's often where the most acute pain is sitting. Partners of people with newly discovered sexual addiction are in a state of trauma. Their nervous system is activated, their thinking is fragmented, and their pain often comes out as rapid fire questions, accusations, or global statements like, "You've ruined everything," or "I will never trust you again." These statements are emotionally true, but they don't give the person in recovery anything they can actually respond to. And they often escalate the very shame spiral that shuts the addict down. Your job is to help the partner translate their pain into specific, actionable needs. So when a partner says, "I can't trust anything you say," you might reflect that back and ask, what would help you begin to feel safer? Is there something specific you need from him this week? You're not dismissing the pain, you're giving it somewhere to land. And over time, you're teaching the partner how to advocate for themselves in a way that invites response rather than triggering defenses. Now, let's turn to the person in recovery because they need something from you that they often don't know they need or can ask for. When the partner expresses pain, the person in recovery almost always hears it through the filter of shame. What the partner says is, "I need you to be honest with me." What the addict hears is, "You're still lying to me, and you're probably not capable of being honest." That triggers defensiveness or withdrawal, which confirms the partner's fear that they still can't get the truth. You need to hold the person in recovery accountable while recognizing that the shame driving their defensiveness is itself a product of deep, often childhood rooted wounding. In practice, this might sound like, "I can see that what your partner just said hit you hard. You look like you want to leave right now. Can you stay with me for a moment and tell me what's happening inside?" You're not rescuing them from accountability. You're helping them stay present for it. One of the most common mistakes I see clinicians make, especially those new to treating sexual addiction, is letting too much happen too fast. Flooding the process with too much truth too quickly can be as damaging as not enough truth. When the partner receives more information than their nervous system can integrate. The result isn't clarity, it's re-traumatization. And when the person in recovery is pushed to disclose before they're ready, you get either a panic-driven confession that's incomplete and has to be revised later, or a shutdown that stalls everything. Your job is to regulate the pace. It means saying things like, I know there's more to talk about, and we will get there, but I want to make sure we're moving at a speed where both of you can actually take in what's happening. In terms of concrete timelines, the first 4 to 6 weeks should focus on stabilization, individual safety, establishing sobriety, getting both people into their own therapeutic support system. Couples work during this phase should be limited. The middle phase, roughly months 2 through 6, is where deeper relational work begins. Transparency agreements, communication skills, and groundwork for formal disclosure. Beyond 6 months, if sobriety has been sustained, you're typically in a position to address the longer-term questions about the future of the relationship. Every couple moves differently, but having a roadmap helps everyone tolerate the uncertainty of the early months. One of the most concrete structures I recommend building early, often within the first few weeks, once initial stabilization of sobriety is underway, is a transparency agreement. Is a jointly developed, explicitly negotiated understanding about what openness will look like going forward. For the partner, it answers, what do I have the right to know, and how will I get that information? For the person in recovery, it replaces the vague fog of, I have to tell them everything, or I'm lying, with specific agreed upon commitments they can actually meet. This might include open device access with no private accounts, a commitment to proactive sharing about recovery activities and emotional state without waiting to be asked, and clear expectations around meeting attendance or how contact with specific people will be handled. 2 things to remember. The agreement should be developed collaboratively. If the partner dictates every term, it becomes punitive. If the person in recovery sets the terms, it doesn't address the partner's needs. And it should be revisited over time. What a partner needs at 3 months looks different from what they need at 12. One of the most critical clinical decisions you'll make is when and how to facilitate a formal disclosure. I want to be direct. Disclosure should never happen in a heated moment, should never be improvised, and should never happen before both people have been therapeutically prepared. The purpose is to give the partner a complete, honest account of the hidden behavior, not a trickle feed of partial truths, which is one of the most damaging patterns I see. Staggered disclosure where the partner keeps discovering new information just when they thought they had the full picture teaches them they can never trust that the truth is really all of the truth. On timing, I have not generally facilitated a formal disclosure until the person in recovery has achieved a minimum of 90 days of stable sobriety and typically 3 to 6 months of consistent individual therapy. If new acting out behavior is revealed after a disclosure, It doesn't just add another injury, it retroactively destroys the credibility of the disclosure itself. As a clinician, you need to review the content in advance with the person in recovery to ensure it's complete. The partner needs adequate individual support in place and an understanding of what to expect. If requested, the partner's individual therapist can be included during the disclosure itself. Most well-timed disclosures happen between 4 and 8 months into the therapeutic sequence. A structured disclosure done well is often the turning point because for the first time, both people are standing on the same ground. As you work with couples through this rebuilding process, you'll encounter 3 cognitive distortions again and again. Idealization typically up in the person in recovery. Everything is great now. I think we're through the worst of it. This often appears after genuine progress, which is exactly what makes it dangerous. When you hear it, affirm the progress while gently reintroducing reality. I'm glad things feel better. Let's make sure we're building on that rather than rushing past it. Minimization most commonly shows up in the person in recovery. It was just porn. It didn't mean anything. Minimization is shame wearing a mask. Rather than confronting it head on, try curiosity. I notice you described it as just porn. Can you help me understand what you think your partner experiences when they hear that word just? Catastrophizing is the most common in the partner. This will never get any better. Our whole world, our whole relationship, it was all a lie. These statements are driven by real pain and should first be met with genuine empathy. But left unaddressed, catastrophizing becomes a fixed narrative that closes off the possibility of change. Your role is to validate the feeling while holding space for a different outcome. I hear how hopeless it feels right now. What you're feeling makes complete sense. I also want to hold open the possibility that this isn't the whole story. Here's what I want to leave you with. When a couple arrives in your office in the wake of sexual addiction and betrayal, the temptation is either to dive in and process everything at once or to pull back and focus on stabilization without ever getting to the deeper work. Structure gives you a third option. It allows you to hold the intensity without being consumed by it. And it gives both people the sense that there's a plan, a pace, and a direction. You don't have to take sides to be effective. In fact, taking sides is one of the fastest ways to lose this crucial work. What you have to do is build a container strong enough to hold both people's pain and walk them through the process with clarity, compassion, and enough structure to keep the healing on track. When we do that, we give couples something they desperately need, the experience of being held by something bigger than their crisis. I wish you well.